Hello, my name is Kieran Das and I'm a junior doctor working at the Royal Derby Hospital, and welcome to my presentation describing how lower patient BMI, choice of energy device and smaller port size are associated with a significantly shorter operating time for total laparoscopic hysterectomy. Please feel free to pause the presentation at any time to review any of the graphics. Hysterectomy is the most common gynecological operation performed, with the use of laparoscopic techniques fast becoming the gold standard method for multiple gynecological conditions. Total laparoscopic hysterectomies have their advantages, including less pain, greater views of the surgical field, fewer infections, and faster recovery times. However, an important consideration compared to total abdominal hysterectomy is the longer operation duration frequently seen in the literature. It is widely documented that surgeons are required to complete a certain number of laparoscopic hysterectomies to become optimally skilled, the so-called learning curve. This learning curve can be steep and affected by numerous patient and operative factors. Investigating TLH operating times is particularly relevant. Shorter operations can convey shorter stays for patients and allows a greater number of patients to be treated, which is especially important given the rising incidence of gynecological malignancies. The aims of this study are to assess if TLH operation duration has changed over the study period, to assess if operation duration is affected by patient factors such as body mass index and indication for surgery, and to assess if operation duration is affected by intraoperative factors such as energy device used, anesthetic choice, entry technique, or vaginal closure material. To achieve this, we retrospectively analysed operative details from all TLH procedures performed at the Royal Derby Hospital by its highest output surgeon from the 4th of August 2008 to the 3rd of October 2020. This was done using the hospital's electronic operating theatre record system and patient electronic case notes. A total of 593 TLHs were performed in this period. 3 entries were immediately excluded as no operation details were documented for. Therefore, an analysis was performed on a total of 590 cases. This graph shows the mean operation duration of TLHs each year from 2008 to 2020. It demonstrates an average reduction in operating time over the study period of 77 minutes, with the average operating time in 2008 being 141 minutes compared to 71 minutes in 2020. Furthermore, the average operating time in 2020 is significantly less than the average operating time in the following years: 2008, 2010, 2011, 2012, 2014, 2015, and 2016. Further analysis has also shown that there may be a plateau in operation duration somewhere between the 351st to 400th case performed by this surgeon. Patient factors such as body mass index also have a significant impact on TLH operation duration. This graph demonstrates how patients with BMI in the widely recognized healthy range of 18.5 to 24.9 has significantly shorter operations than those patients with BMIs greater than or equal to 25. In our centre, the 2 most widely used energy devices were the harmonic energy device by Johnson & Johnson and the Thunderbeat by Olympus. Our surgeon's overriding preference was to use the harmonic scalpel for the majority of their cases. Therefore, only cases performed during the years where both the Thunderbeat and harmonic scalpel were in active use were analysed for this. The analysis revealed that operations using the Thunderbeat energy device were significantly shorter than operations using the harmonic scalpel. Over the years of our study period, the use of a 5mm scope port became ever more common, and our results showed that on average the use of a 5mm scope port was associated with a significantly quicker operation than those using a 10mm scope size. Further analysis on other patient and operative factors was also performed. Other patient factors such as indication for surgery, whether that be either benign or malignant, showed no effect on operating times, and other operative factors such as addition of spinal anesthetic, abdominal entry technique, or vaginal closure material showed no effect on operating times. In conclusion, nearly 600 TLH procedures were performed by the highest turnover surgeon at the Royal Derby Hospital between 2008 and 2020. Our results show an overall downward trend in operating time, and this reflects the TLH learning curve and the experience required to become maximally efficient and proficient at performing the operation. The downward trend may also support the move towards day case operating, allowing greater time for patients' post-op recovery. Furthermore, patient factors such as increased body mass index are significantly associated with increased operating times. This demonstrates the surgical challenges involved with morbidity and highlights the need for pre-op patient optimization, particularly in the cases of non-urgent benign disease indications. Operative techniques such as variation in energy device choice and scope port size have shown some significant association with reduced operating times. However, this should not be a substitute for surgeon preference, as they may feel more comfortable using some techniques over others. Further multivariate analysis into complication rates associated with these different operative variables is currently underway and will give us basis to make further recommendations regarding operative technique. In conclusion, the study has shown or proven the need for consistent practice and experience required to become maximally efficient at performing TLHs. It also demonstrates the impact of patient and operative factors on the procedure. Further multivariate analysis on these patient and operative factors is recommended to determine the true significance of such, along with surgeon experience, as independent factors in the performance of more efficient TLHs. I would like to thank you for listening to my presentation, and many thanks to the BSGE for the opportunity to present. I would now like to welcome any questions.